So, I mean, I think ctDNA is not going anywhere. I think we've learned to embrace it and, individualize the conversation around it with our patients. There's plenty of data to suggest its prognostic benefit, really not a lot of data for predictive benefit. But I do think as we talk about personalized management, even in the neoadjuvant setting, ctDNA could be a valuable tool. As we talk about DB-11, I think some of the thing that has been considered is in a subset of patients, could you consider doing THP initially and then seeing their response? Could ctDNA be one of those sort of points or decision, crossroads, and then you can escalate to the 4 cycles of, give them 4 cycles of TDXT if they're not responding adequately via ctDNA. So I think it's definitely going to be well integrated. We don't have that kind of data to comment right away, but I do have individualized conversations with patients on escalation and de-escalation. If they're not tolerating it well and they're clearing their ctDNA, that's also an important thing to consider.
How are you surgeons thinking about ctDNA?
Well, again, I think it's a really interesting opportunity for us to have another piece of information that helps us to assess response, right? So some of the, I think most cutting edge surgical trials in the HER2 positive space right now are looking at patients who achieve a breast PCR, and then perhaps we don't need to do any surgical staging of the axilla at all, because we know that in patients, again, with HER2 positive and triple negative, if they've achieved a breast PCR, the likelihood they still have disease in their nodes is about 1%. And so there are 2 ongoing trials right now where the patients are not getting any surgical staging. And so I think adding information like ctDNA on top of our imaging to really help select people who are most likely not going to have any residual disease will help us, again, challenge these paradigms of who really needs surgical staging or who needs breast surgery. I don't really want to put myself out of a job, but my daughter's through college, so it's okay.
Congratulations.
But, again, exceptional responders. We have a little bit of data on this from the MD Anderson group where they're doing cord needle biopsies to confirm PCR and then just breast radiation. And I certainly don't think that that's necessarily ready for prime time across the board. But it's hard to ignore, again, when we're seeing these rates of PCR in the 85% range, in the ER-negative HER2 positives, it's hard to not think that that's not the future, and ctDNA will likely be a part of making those decisions.